high school there, which is not in my district. And I just thought, why would you do that?
Excuse me. Okay, let's go ahead and get started. Today is Wednesday, July 30th, 2025. This is the Medicaid Oversight and Advisory Board. This is our second meeting. And Secretary, please call the roll.
Senator Berg. Senator Carroll.
Here.
Senator Meredith. Senator Richardson.
Here.
Representative Heverin. Representative Marzian.
Here.
Representative Mosier.
Here.
Representative Williams.
Here.
Vicky Yates Glisson.
Here.
Holly Harris. Joe Petrie.
Here.
Steve Shannon.
Here.
Senator Douglas.
Present.
Senator McDaniel. Representative Bowling.
Here.
Representative Petrie.
Here.
Allison Ball.
Heather Wagers representing for Auditor Ball.
Beth Bowling.
Here.
John Hicks.
Here.
Lisa Lee. Sheila Schuster.
She is en route. She's stuck in traffic. I'm her assistant.
Stephen Stack.
Here.
Tom Stevens. Co-Chair Fleming.
Chair, here.
Co-Chair Rocky Adams.
What were you going to say? Here. All right, we have a quorum. Everyone seems to be here or have a surrogate in attendance, which is very good. We do just a couple of housekeeping items before we get started. So in your information packets, it's kind of thick this week, but what you'll see is some information in there that was a follow-up from a lot of the questions that were asked and posed at last month's meeting, and including but not limited to information on provider taxes, optional and mandatory Medicaid services, and a copy of the 1115 community engagement waiver. So check that out today and take it back to your respective organizations. And then also, if members have comments, announcements, or general questions not related to today's presentation, please hold those and until the end of the meeting, and there'll be a time for us to kind of go through those following public comment. So, housekeeping is taken care of. I guess the next order of business is we need approval of the minutes. So, do I have a motion to approve the minutes from June 25th, 2025? I hear a motion. Do I have a second? I see a second. All those in favor signify by saying aye. Aye. Any opposed? All right, the minutes are adopted. Okay, next up on our agenda is we have someone from the National Conference of State Legislators who is going to present today and give us an update on the federal changes to the Medicaid program.
Thank
She's on
you,
Zoom.
Chairs Rocky, Adams, and Fleming. Can you hear and see me?
I can hear you, but I can't see you. Ooh, I can see me, and I can see Chris. There you are.
Okay, I was like, I'm not sure how to change that on my end.
Yeah.
There we go. Can everyone
Okay,
hear and
just
see me all right?
introduce yourself for the record and then proceed.
Excellent. So my name is Catherine Costanza, and I'm a program principal with the National Conference of State Legislatures. I'm here to present on the Medicaid provisions in 119 HR 1, and I'll go ahead and start sharing my screen and the slide deck now. All right, can everyone see that okay? Excellent. Okay. All right. So as I said, my name is Catherine Costanza, and I'm talking about the Medicaid provisions in 119 HR 1. But if you're not familiar, very briefly, just wanted to flag that the National Conference of State Legislatures is the membership organization for state legislators and legislative staff. We are both nonpartisan and bipartisan, and we provide to the over 7,000 legislators and over 20,000 legislative staff in all 50 states, DC, and the territories, all the services that are listed on this slide, including nonpartisan policy research and technical assistance presentations like this one, as well as connections, trainings, federal advocacy in DC, and meetings where members can exchange information. So just to flag that if you do have any questions after this, there's a lot to cover and we may not get to all of it, but please don't hesitate to reach out to me directly, and either I or one of my wonderful colleagues at NCSL can provide you with more information. So with that, I've been asked to present on the Medicaid specific provisions in HR 1. So as we dig in, we'll provide first a high level overview of kind of what the landscape is in the bill. Then we'll dig into new flexibilities and funding opportunities that we want to highlight, and then we'll dig into the major provisions. At the end, I'll wrap up with some key questions that you all may want to consider as policymakers or in recommendations to policymakers. Before we dig in, I do want to acknowledge that there is a lot in the bill, and there's a wide range of political and partisan perspectives on these provisions. And just to reiterate that NCSL is a nonpartisan and bipartisan organization. We take no position with respect to any of the provisions in the bill or any actions that states could or should take in response. My job today here is just to share what it is that we know about the provisions as well as remaining state flexibilities and highlight what may be most impactful to Kentucky. So let's dig right on in. So at a high level, there are 4 key takeaways about the Medicaid provisions in HR 1. Specifically, it includes more than 20 provisions, and they're fairly complex in how they operate within the program. We're not going to get to every single one of them today, but I've tried to highlight what is most relevant to states and flag what is more miscellaneous and may be less impactful overall. The policies are complex and they also range in their potential state impact. So provisions include changes to federal and state financing, most specifically through provider taxes and changes to provider taxes. It limits state flexibilities related to eligibility determinations and payments to providers through state-directed payment limits. It will have some coverage impacts for people covered by the program, and it also includes some funding opportunities and a new waiver flexibility. 5 of the policies in the bill account for 85% of the federal savings over 10 years, and we're going to walk through these in more detail. And I want to flag that those policies address cost drivers for the federal government, and that includes enrollment, particularly expansion enrollment, provider payments, particularly for hospitals, and state financing arrangements through provider taxes. Now, while cost drivers in the Medicaid program are often shared between the federal and state government, it's important to recognize that some of the provisions and policy changes may mean that states do not realize the same savings as the federal government because of the changes to state financing arrangements and also the state's role in implementing the provisions that are in the bill. So what are the 5 policies that account for over 85% of federal savings? And I do want to flag that this is over 10 years. So all of the dollar amounts on here are over 10 years, between 2026 and 2034, I believe. So first off, the work or community engagement requirements are a significant component. Changes and repeal of Biden administration eligibility and enrollment rules that states will either have to undo some of their work in complying with the rules originally. Some of the remaining rules do remain in effect, and states will continue to implement those. Changes to provider taxes, specifically the reduction in the hold harmless threshold for provider taxes, are a significant portion of the federal savings in the bill, as are limits on state-directed payments, which are payments to providers that up until the enactment of the bill could be up to the average commercial rate. And then increasing the frequency of eligibility determinations for the expansion population from once annually to twice annually, so every 6 months. A couple key things to keep in mind is that the fiscal impacts of the bill are backloaded. And so over 76% of the 10-year reductions would occur in the final 5 years of that 10-year period. So 2029 to 2034. Expansion states and changes to expansion state financing account for more than half of the potential federal savings that are in the bill. And there's a significant impact on provider payments, particularly for hospitals. So Manat and the State Health and Value Strategies organization estimate that the provisions in the enacted Senate provisions could result in an 18.2% reduction in hospital payments that are equivalent to over $660 billion, again, over that 10-year period. So when we're looking at the timing, there's over 20 provisions. What are we talking about in terms of when things go into effect? Well, all the Medicaid provisions go into effect either upon enactment or sometime before October 1st, 2029. So there's about a 5-year implementation period. So starting in 2025, there are several provisions that take effect immediately, but most relevant for state action in 2025 is that applications for the Rural Health Transformation Fund are due by December 31st of this year. So there are several provisions that do go into effect, but most of the 2025 provisions are more focused around pausing or prohibiting new arrangements from going into effect. They are not an implementation of something new per se. In 2026, I mostly want to highlight that there are several implementation deadlines related to eligibility in the program, specifically eligibility related to worker community engagement requirements, the increased frequency of eligibility determinations, and changes to immigrant eligibility. And the reason that I point this out is because one of the provisions in the bill, the erroneous excess payments provision, which we'll talk about in more detail, can change the amount of payments that the federal government can recoup from states, and it's tied specifically to eligibility, the accuracy of eligibility determinations. So state activity implementing the eligibility provisions in 2026 may have downstream implications in 2029 and beyond. In 2026, limits on new provider taxes also go into effect. And in 2027 and beyond, specifically starting in 2028, provider taxes, existing provider taxes are reduced, state-directed payments are reduced over 5 years each, and new flexibilities come into effect related to that new home and community-based services waiver. The very last provision to go into effect is the erroneous excess payments provision, which again, we're going to touch on at the very end. But some of the implementation, as I mentioned, will impact what may come up in that erroneous excess payments for states. And I just want to flag, this is non-comprehensive. This is not a comprehensive timeline of all the provisions, but if you would like one, we have linked to a resource from Manat and the State Health and Value Strategies that has implementation dates for every provision in the bill, including the marketplace provisions. So, this only accounts for Medicaid. The changes to marketplace plans will go into effect in a front-loaded way, more in 2025 and 2026. So tying it all together, the timeline and scope of impact is going to vary by state and policy. The federal bill does limit state tools and flexibilities to balance state Medicaid budgets, particularly through changes in provider taxes, but state flexibilities may still exist. Combined effects on provider payments are significant, but not all providers are impacted equally. And as the legislators on the board know, Medicaid is obviously only one piece of your state budgetary puzzle. There's other changes in the bill related to SNAP and other budgetary priorities in which Medicaid is only one component of those. And stakeholder involvement in proactive planning, such as what the board is doing right now, may help states wrap their arms around policies that may be needed. So, digging into the new flexibilities and funding opportunities specifically. I'll flag for this that for all the provisions in the bill, I have used the same slide format to make it a little easier to read. I know this may get a little monotonous over time, but I wanted to make it easy to understand. So we'll briefly walk through what each provision does, its effective date, and then any state application considerations. And again, happy to follow up after the presentation if you'd like more detailed information on anything specifically. So first off, the bill included a rural health transformation fund that appropriates $50 billion in rural health transformation grants over 5 years. So it's allocated $10 billion per year starting in fiscal year 2026 through fiscal year 30. State applications are due by December 31st, 2025. And there's set statutory language around how the funds will be allocated. So 50% of the funds will be allocated to approved states equally, and 50% of the funds are allocated to at least 1/4 of those approved states based on rural factors, such as the percent of population that's rural, percent of health facilities that are considered rural, and hospital financial status. Applications must include a rural health transformation plan, and the funds cannot be used to make up the state share of Medicaid funding. CMS is the administrator of the grant program, and applications must be made through the governor's office. So things to keep in mind there. Additionally, there's a new home and community-based services waiver that will go into effect in July 2028. So this particular waiver allows states to establish home and community-based services waivers for individuals who do not need an institutional level of care. It also appropriates $100 million in state grants to support the home and community-based services system, which are allocated in fiscal year 2027 ahead of the effective date of the waivers. And the grants are allocated based on the proportion of home and community-based services population in the state compared to all states. The state has to make some attestations that the waiver will not increase the average waitlist duration for individuals who need care, but the additional details on the grant application are to be determined and will be forthcoming from CMS. So now pivoting into more of the major and miscellaneous provisions. There are other funding opportunities in the bill, but they are specific to certain state implementation activities, so we have included them in this section as well. I have also tried to group them together into similar policy groups. So the first group, we're going to talk about changes to expansion eligibility. The next group will talk about state financing and payment changes. And then there's a bucket of just miscellaneous access, eligibility, and financing impacts to consider in some of the more major provisions that will have impact on states. So to dig in, we're going to start with changes to expansion eligibility policy. So first off here are changes to work or community engagement requirements. So expansion states, including Kentucky, are now required to implement work or community engagement requirements for the expansion population as a condition of eligibility. The statute includes qualifying activities, as well as mandatory exemptions, and some additional state flexibilities related to short-term hardship waivers, other things like that. The bill also is a little bit confusing in state flexibilities related to Section 1115 waivers. There's some ambiguity here that will require clarification from CMS. So specifically, the bill prohibits 1115 waivers to waive implementing work requirements, but it permits Section 1115 waivers to implement them ahead of the 2027 deadline. It is not clear what effect these waivers will have on, or effect the statute will have on 1115 waivers that do not align with the statutory requirements in the statute. So for example, Kentucky has a community engagement 1115 waiver that it submitted in May of this year, and that waiver does not perfectly align with the federal statutory requirements, and so it is not clear how if CMS will approve it as is, or if it will require an amendment to align with the provisions in the statute.
Catherine, I'm going to stop you right there. I don't want this to be super formal, but I do have a question from my co-chair, Ken Fleming.
I thought you were going to ask a question for me.
No, it's all you.
I just want to, my understanding, and this is real for maybe Dr. Stack and Commissioner Lee, is that it was approved, but we're out of compliance. We don't match to it. And then if that's the case, how are we going to go? What's the cabinet's plan in order to accommodate or
Meet the
threshold that's just came down?
So our 1115 waiver for community engagement has not been approved by CMS.
Okay.
It is still, I think, under public comment, and we have not received communication from CMS. So we will wait until we receive that communication and guidance before we move forward with any community engagement activities under the waiver.
And then my understanding, there needs to be a second comment period. But they basically gave you sort of a tentative approval, but we need to go through the private to another one, because that's what I. And then, but the guess thing is, if they do not approve it or whatever, what's the contingency plan the cabinet's going to have in terms of addressing that, and what's the time frame?
So we have not received contingency approval for the waiver, but again, our plan is to wait on guidance from CMS, and then once we receive that guidance, we will either have to amend our waiver or complete a total new waiver if they deny it completely.
Okay, thank
And the timeline on that?
Well, the timeline is, as you notice, based on federal rules, we have to have the community engagement waiver in place by 2027. The work requirement is going to affect January 1st, 2027. So we would have to have a waiver completed and approved by that time, or we could submit a request for an extension for until 2028.
Okay, thank you. All right, Catherine, please proceed.
Excellent. Well, Commissioner Lee just lovely walked through all the effective dates very wonderfully. I'll also just flag that the bill also appropriates $200 million in grant funds to go towards state implementation of worker community engagement requirements, and those grants are allocated in 2026. But we will need to wait until CMS issues guidance to understand the scope of state implementation, and the statute mandated CMS issue an interim rule by June 1st, 2026. And with that, there we go. All right, so the next expansion eligibility change is there's two policies here. There's the increased frequency of redeterminations and new cost sharing in the bill. I do also want to point out there was an error in some of the information that I had on this slide deck that was distributed to you, so I will redistribute that out and follow what I say on this presentation here. So on the increased frequency of redeterminations, it does require states to redetermine eligibility for the expansion population every 6 months instead of annually. And that goes into effect January 1st, 2027, similar at the same time as the work requirements. For the cost sharing, this is where the error was on the original slide deck, my apologies. For expansion adults with incomes between 100 to 138% of federal poverty line, states must impose co-payments on all services except for those that are exempted under existing laws, such as primary care services or substance use disorder treatment. It also caps cost sharing at $35 per service and at 5% of total annual family income. This provision goes into effect a little later, so October 1st, 2028. And Kentucky is subject to these requirements as an expansion state. So current eligibility and enrollment practices will inform the cost and coverage impacts here. So some states already conduct periodic data checks, but there are ongoing costs associated with increased staffing needed to conduct more frequent redeterminations, as well as assess cost sharing and compliance with cost sharing. All right, so our next bucket of policies is related to state financing and payment changes. And these are specifically the provider tax limits and state-directed payment limits. So the provider tax limits There are 3 policies here. So we're going to walk through each of them one by one because they each have slightly different effect. So the first is what has been referred to as the moratorium on provider taxes. So the moratorium is essentially that there is one requirement required for provider taxes called the hold harmless threshold. And what it does is it requires that states do not hold harmless the taxed entity for the taxes that they pay. They can't return all that back to the provider. And what the moratorium essentially reduces that hold harmless threshold. It used to be set at 6% of net patient revenue for a class of taxed providers. And it reduces that for new taxes down to 0% for all states. And the moratorium goes into effect October 1st, 2026. But the text is complex, and the impact on state flexibilities between the enacted date of the bill and October 1st, 2026 are still a little to be determined. So I just want to flag that for you. That's the first bill, the moratorium. So any new provider taxes are reduced down to that 0% hold harmless threshold. It's intended to be a moratorium on states using or implementing new or increased provider taxes. The second provision is the hold harmless threshold for existing taxes. So these were taxes that were enacted by the state legislature or approved by CMS prior to the July 4th of this year. Those existing taxes will be reduced down from 6% of net patient revenue down to 3.5% of net patient revenue in expansion states at starting January 1st, 2028, and then reduced down annually by 0.5% until it reaches that 3.5% threshold. So any taxes that are above that 3.5% threshold will only be impacted when the net patient revenue threshold exceeds whatever the threshold is for that year, if that makes sense. Nursing facilities and intermediate care facilities for intellectual and people with intellectual and developmental disabilities are exempt from the reduction in the hold harmless threshold. So for nursing facilities and those ICF IDDs, their threshold will remain at 6%. And again, this all starts in January 1st, 2028, and is implemented over 5 years between January 2028 to 2032. And then finally, sorry, go ahead.
No, I'm sorry to interrupt, Catherine. Can you provide the board a little more in-depth or understanding of, we're at 6, but let's go down to 5, and so even though it's affected on 2028, doesn't that go to 2029? And then in addition to that, from that point forward, what's your understanding in terms of what the impact's going to be on our cost, not on a dollar amount, but on a percentage basis, and using using any type of rates or any situation? I hope I'm getting this the right subject applied to this situation. Does that make sense?
I think so. So it sounds like your first question is to the effective date and when the provider tax reduction threshold will take effect. Am I saying that correctly?
Yes, ma'am.
Okay. So starting January 2028, the threshold is now 5.5%. And then starting January 1st, 2029, it's 5%. It's reduced down 0.5% annually over 5 years until it reaches the 3.5% threshold. So let's say that Kentucky, we know from KFF budget surveys, although I'm sure Commissioner Lee has more detailed information for you on this, but Kentucky does not have any provider taxes according to KFF's annual Medicaid budget survey that are above 5.5%. So you would not be affected, it sounds like, by that first reduction in starting January 2028. That said, let's say you have a hospital tax that's at 4.2%. I'm making up numbers here. Don't quote me on this. I'm just making things up. But if you have a hospital tax that is at 4.2%, when that threshold is reduced down to 4% in, I think it's 2031, all of a sudden that hospital tax that is at 4.2% will then be reduced down to that threshold. And then the following year, it will be reduced down again to 3.5%. So it has kind of a tiered effect. This is part of the reason that those fiscal impacts of the bill and the federal savings accrue on the back end. They are in aggregate and they add up over time because provider taxes are reduced over time.
Okay.
And I think that got to the first question. Can you repeat the second question for me? I think I would like to understand that better.
Be honest with you, I ignore the second half of that because I'm thinking of another situation that would apply to, so you can ignore that. But I do want to point out or comment on the top portion of that slide. It says, according to the Kaiser Foundation, hospitals and the managed care won't be effective, likely won't be affected. Based on what we're seeing, it will be affected. So I don't know if you can comment on that.
I can't comment on it. So I'm taking this from KFF conducts an annual budget survey of state Medicaid programs, and they compile that information into 50 state surveys. I am certain that your commissioner has more accurate information than their broader national survey, and it also probably more up-to-date information. Their surveys, I think, are conducted early on in the year and then published later in the year, and then we use them for a year. So I am certain that this reflects somewhat out-of-date data as well.
Sure.
So I would go with whatever Commissioner Lee is telling you.
Okay, all right. Well, I'm sure the commissioner has that information. I just want to make sure.
And I do also want to point out there's a third provision related to provider taxes here as well, and that's limit on provider tax waivers. These are not your general Section 1115 or home and community-based service waivers. These are niche waivers that are only used for provider taxes. I'm actually not sure if Kentucky has one. We don't have national data on which states have provider tax waivers, but these are often used to tax hospitals or managed care organizations in different tiers. So for example, it might tax rural hospitals or children's hospitals in a different tier than your general acute care hospitals. Just flagging that this does make changes to those provider tax waivers effective as of the enactment of the bill, but states will have 3 years to transition their payment arrangements in case that is something that impacts Kentucky. So also related to state financing and payment changes are changes to limits on state-directed payments. So the bill, state-directed payments, what they are is in states that use Medicaid managed care delivery systems, so they contract with private commercial insurers to administer Medicaid benefits and pay providers. The state can direct payments through the Medicaid managed care organizations to a particular class of provider for certain approved purposes. What makes state-directed payments unique is that states can pay a class of providers an additional payment above their base rate up to the average commercial rate, which typically exceeds what Medicare pays for an equivalent service, if there is an equivalent service. So that's how state-directed payments have operated up to now. So what does the bill do? Well, the bill caps any, again, new state-directed payments. So these are non-approved, would be new in existence. It caps any new state-directed payments at 100% of Medicare, or if there is not a Medicare equivalent service, for example, for home and community-based services or a lot of behavioral health services, at the state Medicaid fee-for-service rate. And expansion states are capped at 100%, non-expansion states are capped at a slightly higher percentage. Certain payment arrangements that were approved or submitted by July 4th, so by the enactment of the bill, are grandfathered for the next 4 years. But starting in 2028, those grandfathered payments are reduced by 10% annually down to the 100% of Medicare limit, that upper payment limit. So it's similar to the provider taxes. Starting in 2028, those annual payment reductions for providers go into effect. So any provider payments that are above 100% of Medicare will be reduced by 10% every year until they reach 100% of Medicare. Or the state equivalent rate, because Medicaid is unique in a lot of ways for some of the services that it covers, and there are no Medicare equivalent rates for some services in the program. There's also overlap in the timing between the distribution of the Rural Health Fund and phasing down of directed payments between 2028 and 2030. So Kentucky, as an expansion state, is subject to the 100% of Medicare cap. And again, according to KFF, this is the budget survey I was referencing. They're using data from their annual budget survey that I was referencing before, so it may be out of date. Your Medicaid director is going to have more current information, but according to KFF, Kentucky would likely need to reduce hospital or nursing facility payments to comply with reduced rates at some point in time. And as of CMS's website, Kentucky has 11 approved state-directed payment preprints from various rating years. Some of them are related to value-based payments for academic medical centers and hospitals, and some provide uniform rate increases to emergency ground ambulance providers. So those are some providers and purposes that may be affected by limits on state-directed payments. And in February this year, your Cabinet for Health and Family Services estimated that changes to state-directed payments could put $5.5 billion at risk, 1.1 of those of state-only dollars. However, that was in February of this year, so that may be different under the enacted provisions in the bill, or may look a little different now. Some other considerations is that this limits state flexibilities in the way that states direct payments to certain providers. But states can create new state-directed payments. They're just capped at that 100% of Medicare or the state equivalent rate. And so it's a little unclear how states are going to use that Medicaid equivalent rate, but it's unlikely to be available for hospitals or for nursing facilities, as Medicare has very robust payment methodologies for hospitals and nursing facilities as a comparison. The impacts are going to vary on this by provider type and the purpose of the directed payment. All right, so the next three policies that we're going to talk about fall more into the miscellaneous category of they have miscellaneous effect, but they will have effects on states and either significant implementation or access or financing impacts. And so I wanted to include them here, even though they kind of fall into this miscellaneous category. So the first is the provision that prohibits federal Medicaid payments to Planned Parenthood and similarly situated providers that are called essential community providers. That's the technical term, for 1 year. It went into effect as of the effective date of the bill, but it's currently subject to ongoing litigation. And I flag this mostly to say that the preventative services, so these would be non-abortion preventative services like wellness checks or STI screenings that are provided at Planned Parenthood, may be impacted by the payment limits on this provision, specifically for Medicaid beneficiaries that would otherwise seek services at Planned Parenthood for those preventative services. The next provision is related to immigrant eligibility. So there are two provisions here. One, and the one I want to highlight here, is that for all states, certain categories of immigrants are no longer eligible for Medicaid because they are no longer defined as qualified non-citizens. So this goes into effect October 1st, 2026. And as I mentioned in the timeline, all states will need to update their eligibility systems to reflect this new eligibility. And this applies to immigrants who have legal status, who previously qualified for Medicaid, but will no longer after the provision goes into effect. And the implementation of these eligibility provisions will impact that erroneous excess payment determination and change under the provision of the bill. So flagging it for that. There's also a change here that for expansion states, states are required to provide Medicaid coverage for emergency medical services only for individuals regardless of their immigration status. And so up until now, expansion states have been able to use the federal match of 90% when somebody received emergency medical services and they would have qualified for expansion but for their immigration status. Following the bill, the federal match for those very specific services provided to those specific individuals will be reduced down to the state base rate. This does not otherwise make any changes to the federal match rate for broader services. It's just for the mandatory emergency medical benefit for this subpopulation. And last but not least here, we're going to talk about erroneous excess payments. So this is, I will just say, by far one of the most complicated provisions in the bill. So understanding its impacts, it also goes into effect October 1st, 2029. It's the longest timeline of effectiveness when it goes into effect. So what this means for states is very much to be determined. But broadly, under current law, payments, erroneous excess payments that are in excess of a 3% allowable rate can be recouped by the federal government. And so the bill expands the scope and type of information that can be used to calculate erroneous excess payments, to include all audit results from payment error rate measurement audits, as well as from Office of Inspector General audits, and to include insufficient documentation for eligibility and certain payments for non-citizens. So all of the eligibility implementation that goes into effect for the expansion population and related to immigration status will factor into the calculation of that erroneous excess payment. It also limits the Secretary's authority to waive excess payments that exceed the allowable rate. So just flagging that as more of a long-term potential impact, but that will be impacted by your implementation, particularly in fiscal year 2026. I'm not going to linger on this slide, but this is just the hodgepodge of remaining provisions in the bill. And while every state is different, these are less likely to have significant impact on state budgets, coverage, or operations. And so moving finally into some of the key questions that you may consider as you're evaluating the impact on Kentucky and any potential policy action that is needed. Specifically, the scope of impact, the stakeholders that are involved, and the resources and timing of can you receive resources to implement? What's the timing in which you need those resources? And what are some of the human side of resources that you need? So on the scope of impact, identifying who is impacted by particular provisions. Is it providers? Is it beneficiaries? Or is it the state agency? Do they need additional resources to conduct those eligibility determinations accurately? Things like that. What is the scope of impact, both fiscal or otherwise? So what is the scope and purpose of your provider taxes? What is the percent of that net patient revenue threshold in your state? What are the state-directed payments that you have and what are they used for? What impact will that have on your broader state financing in the Medicaid program? And what are the costs of implementation of some of these provisions? And are there any savings associated with some of these provisions? Stakeholders, who is impacted? So again, I have that listed here twice, but I think it's relevant here. And then who has the data that you need to implement? So for instance, in the work requirements context, will more engagement with industry or employers be needed? Do your managed care organizations have some information that may be valuable? Are there state agencies that maybe separately or independently hold certain data that you might need? What access to data do your beneficiaries have if they're going to need to share it with the state? And then who needs to work together to implement these provisions? And who is responsible for applying for state grants? That may look different depending on the state grant that's available. It may be, as for the Rural Health Fund, the governor's office, or it may be the Medicaid agency more specifically for some of the other provisions. And then obviously the resources and timeline. What's the most pressing timeline for your state? Do you need a special session to address some of the upcoming challenges? Are there grant funds to address the specific scope of impact like we've talked about here? Are there long-term provisions you can plan for now? And then how might elections in 2026 potentially impact any long-term planning? Is that going to impact kind of the continuity of things you're trying to put in place now? And then to the extent that you have the question, what are other states doing? We track state Medicaid legislation in the Health Cost Coverage and Delivery database. And we will be tracking, we will be publishing by the end of September a Medicaid legislative trends brief that includes some relevant information about how states have been thinking through and starting to prepare and respond to federal action. And we have some additional resources here on this slide. I'll just point out this very last one, the Medicaid cuts in the states, tracking state-specific estimates from the state health and value strategies. It will continue to be updated, and it will include, as it says, state-specific estimates of specific proposals as states move into implementation. So that may be a helpful one to check in on as states like yourself are starting to grapple with these policies. Don't hesitate to reach out to me if you have any questions. I look forward to seeing some of you at Summit in Boston, and save the date on your calendar for our annual summit next year as well in July.
Well, thank you very much. That was super informative. It's I almost don't know where to start. I do think that at the very end, it's going to be really critical for states to have an open dialogue to see kind of what's working or what they have found to work in another state, and maybe Kentucky could look at those things. So I appreciate NCSL being really robust in their outreach with this particular issue and what other states are doing. So thank you very much for that. Before I ask any questions, does anyone have any questions before I ask a question? Anybody? Okay, I'm going to start off with kind of what do you know about redeterminations? Are there going to be any regs around how we do redeterminations, and is it a hard every 6 months, or is this kind of on a rolling basis? Do you have any insight on that?
I don't have specific insight on whether the statute requires rulemaking from CMS, although I defer to any experts you have in the room that may know otherwise. My understanding, though, is that absent a waiver of some type, it is a requirement that states redetermine every 6 months. We do have, does that answer the question?
Well, in addition, I was also curious, does it speak to whether government dollars have to be used for redetermination, or can you contract something like that out with a private provider? Or are they silent on that?
I believe it's silent on that. Now, that said, states often contract with third-party vendors to assist in eligibility determinations, or they may have information system contracts that are used to redetermine or to assist in redetermining eligibility. I don't know specifically how Kentucky's eligibility determination system is set up. Some states have county-based eligibilities determinations where, like, the county human service agency determines eligibility for multiple programs, which may include like SNAP and TANF as well as Medicaid. Other states have different statewide systems. Some states kind of streamline their benefits enrollment, things like that. In terms of the dollars that must be used, so the federal state financing is, states are still required to pay their share of whatever the costs are of implementation and of ongoing eligibility and staffing. The exact percentage of what that share is between the federal and state government depends on the activity. But for most administrative services, and it is 50%, so states share equally the cost of administrative activities, including eligibility determinations on an ongoing basis. But for implementing new systems upgrades, it's split at 90% and 10%. So states may be eligible for system upgrades for a 90% match. I can also confirm more about what that match is for different administrative services. It does depend on the activity, so I can provide more information about that.
Thank you. I would appreciate that because, yeah, on page 7, under increased frequency of redeterminations, you do talk under other considerations, the ongoing costs associated with increased staffing. And-
Yes, so we know from, there are some fiscal estimates. Sorry, let me find the slide here. Yes, so some states we have seen actually recently, specifically Ohio and Wisconsin, I know have more recent fiscal estimates associated with increasing the frequency of eligibility determinations, and I'd be happy to share those out. They include some information on system upgrades as well as ongoing staffing costs, because when you're redetermining eligibility every 6 months, you just might need more staff on hand in order to conduct that efficiently in the timeline that you need.
Yeah, that'd be great. I'd like for you to pass that along to the committee because we're anticipating a budget coming from the administration, and I'm assuming that a lot of these federal changes are going to be reflected in that. And so anything that other states are doing would be really helpful.
Absolutely. Happy to share that.
Do we have any questions from any other committee members? Mr. Hicks?
Thank you, Madam Chair. I just want to point out that one of the first items out of the gate is the Rural Health Transformation Fund.
Yeah.
And particularly in the slide that Catherine had provided, that the half of that money may not go to most states. They have to provide at least 25 or 1/4 of the states, right? That's 12 and a half, that get the money. So just a heads up, right? Not everybody's going to get that half of the money.
Can I ask a question?
Yes.
Sorry,
No, you may not.
I may not. Okay. I just, given that the deadline that we need to address these monies is at the end of this year, I think I saw something recently that y'all were taking a proactive approach to this, which I'm glad you're taking a proactive approach, and I'm seeing the nod in the head over the doctor to the secretary. Do you want to address that, which will probably provide a little more understanding of what the process is for the next couple months?
Sure.
Thank you, Secretary.
So this just became a law on July 4th, and there are a number of things that were not entirely clear. Some of this is subject to the CMS administrator giving some additional detail about what's required in an application and how to apply. So all the states are still awaiting that guidance and that clarity. In the meantime, we just released a couple days ago a solicitation to a large group of organizations in the state asking for their input, their suggestion and ideas. We have emphasized that this is intended to be transformative to rural health care. This is not to pay for clinical services. This is to rethink how we can make sure that rural health care has access to high quality, accessible care. And so we'll see what we've given till August 31st for people to give us proposals and their ideas. We've encouraged them to work together with each other. And in the meantime, we're pretty confident that we'll have more guidance from CMS as August unfolds about what they're going to want, and that will help inform how we have to package this to put it together for an application. And like Secretary Hicks said, there's $10 million a year each year for 5 years, divided in 2 pots. It's not entirely clear if every state who applies will at least get $100 million or more in the first pot. It's all approved applications, so it's not clear if they'll take a permissive approach and just say everyone who applies at least gets that first half of the pot, their portion, and then the second portion, like Secretary Hicks said, that's determined based on their assessment of it, the rurality of your state, like the number of facilities that are in jeopardy, how rural your population is. There's some guidelines in the legislation, but the details are really, there's a lot of discretion given to the CMS administrator to determine that.
Clarification. Like, I just one thing that Chairman Petrie did some time ago, particularly when it comes to COVID, we use those as not to support reoccurring costs. It's a one-time, provide a little seed, and hopefully things. I thought I read something that's the position you all are taking, that we're not going to support any type of reoccurring cost. This is going to be a one-time support of a whatever it might be, and not find ourselves on a cliff of saying, "Oh my gosh, we're going to be in a deficit because of this." We don't have any, we're not being mindful of that process.
Yeah, so we emphasized, and it's a short one-page letter, but we emphasized that it should be for transformative proposals that are replicable, that are scalable, that's a one-time funding opportunity for a time-limited duration. So yes, these should not be looked at as a source of ongoing, recurring reimbursements to sustain things. It has to be seed funding to really restructure and build something sustainable. So I think, again, we tried to keep it concise with the solicitation part of it, but the goal is exactly, I think, what you said is there's no messaging, there's no anticipation there will be funding past the initial 5 years. And so we have to assume, for the sake of this exercise, that we'll have whatever money we get awarded will be a one-time award with a 5-year spending horizon. There's other constraints within it. The year you get the money, you have to use it by the end of the next year, and whatever you don't use gets clawed back and then redistributed by CMS. So there's other parameters in there. I think it'll become more clear over the next couple months, and hopefully by soliciting input from stakeholders, and we'll receive input from others who we may not have solicited. We'll try to pull that together and create a process to try to be participatory and open about how we do that. Thank you.
Yeah, can I just ask you one more thing on that? So the Rural Health Transformation Fund, do you view that in terms of just rural hospital facilities, or do you view that as rural health?
Yeah, so the bill actually talks about substance use disorder, mental health, hospitals,
Okay.
telehealth, and it's not even just limited to rural communities per se. So if you think about it, if we have to rely upon more patients being transferred, to larger hospitals for care, is there a way to ensure that there is access to reliable and high quality follow-up care locally? That may not be the inpatient care, but it may be the follow-up care. Are there ways to invest in telehealth? Are ways to invest in new IT systems that make the sharing of information more effective and supporting for folks? So it really leaves the possibility for investing in the Kentucky healthcare system, but its first and foremost goal is to invest in that system in such a way that projects high quality, accessible care to rural populations.
Vicki Yates Glisson. Microphone.
One of the questions I had from our NCSL presenter was, even though we know that there, as Secretary Stack mentioned, that there's some guidance in the statute about how they're going to look at how rural you are and the susceptibility of some of your facilities are in the rural area and so forth. And there's not and the application isn't out there yet. I was hoping that maybe she might have some indication of some other guidance that would be out there that she may have heard of that might be helpful beyond what's in the statute. That would be helpful, because the way I read this, we don't have a lot of time to get it prepared. We need a plan. And if we don't do a plan initially that is submitted by December 31st, we're kind of out for the whole rest of the 5 years. So we have to get this done, and it's going to guide what our funding would be within this next 5 years. So this is a very, very, to Secretary Hicks' point, this is a very important exercise that it's the first thing out of the gate, and it's going, I know it's not maybe a whole lot of money, but it is out there, and we need to make the most of it. So I would like to know if there's any other thoughts that she has, any guidance that she's picked up that would help, because we need to get on this very quickly and make the most of it, because it's going to affect us for the next 5 years.
Thank you very much for the question. Unfortunately, I don't have a more satisfying answer than Secretary Hicks. We're waiting on CMS guidance, although we have heard from some of our we meet regularly with other state-facing organizations, and we have heard from those that are in closer contact with CMS that this is a priority. And so we are hopeful that we would see in the next several weeks and/or month, more dedicated guidance from CMS. One thing I will say, though, is that the statute does have helpful information. There's a nice summary, again, that KFF has put together that I'd be happy to share out, that includes some of the factors and priorities that can be listed in the Rural Health Transformation Plan. So as Secretary Hicks mentioned, it does mention addressing opioid use disorder, alternative payment models for rural health, and some other state priorities. Additionally, there may be existing resources within your state. So not every state has their own Office of Rural Health, but if there are state agencies or entities that have already been working on rural health in your state through your state Department of Health or through other activities that may be ongoing in your state, they may already have existing plans and documents that could be used for this, although I imagine Secretary Hicks is probably in the best position to speak to some of that. But just flagging that you may not be starting from scratch as a state in terms of where you could allocate it, and the statute does have a more specified list of what needs to or could be included in the Rural Health Transformation Plan, but we are just waiting from CMS for additional guidance.
All right. Any more questions for Catherine? Yes. Representative Marzian.
Thank you, Madam Chair. Thank you for your report. Very interesting, and we got a lot to do. But my question, I think, is a follow-up on your, Senator, is we're going to increase the frequency of eligibility requirements to twice a year, and it's saving the federal government $63 billion. I guess that's nationally, but how much would that then be sent to the states to have to spend, especially Kentucky, if we're going to have to do twice a year eligibility? Are we going to have about $1 billion or so that we're going to need for that?
Thank you, Representative Marcian. That's a great question. I don't think I'm not sure that has an easy answer or one that you can know before you've implemented the requirement. So there will be some upfront implementation costs. Again, I'll share out those fiscal estimates. But the federal and state government share financing responsibility for the Medicaid program upfront. So it's not like when the federal government obtains savings that they then split the difference with the states. The savings that are estimated related to the redetermination of eligibility come from transparently coverage losses. So the expectation that redetermining eligibility will identify individuals who are no longer eligible for the program and who are no longer eligible for coverage. So there will be implementation costs associated with that. Kentucky may experience some state savings that are associated with reductions in the number of people that are enrolled in the program because of those mid-year eligibility determinations. But how that washes out on the back end between implementation costs and changes to enrollment is to be determined, unfortunately.
Thank you.
All right. Any other questions? All right. Thank you so much for your presentation. It's very helpful. And everybody make note of her contact. If you have any questions, follow up with her. And anything that she sends forward, I'll make sure are in the packets for next month's consideration. Okay, next up, we have Nancy Galvani, President and Chief Executive Officer of the Kentucky Hospital Association. We're going to talk about state-directed payments, provider taxes, and Rural Health Transformation Fund. All the good stuff. Yeah, please take a seat. And just because it's perfunctory, just say your name again and please proceed.
Good afternoon. I'm Nancy Galvani, President of Kentucky Hospital Association. So Chairwoman Rocky Adams, Chairman Fleming, members of the board, thank you so much for inviting me here today to really talk about the new reality facing Medicaid in Kentucky and the impact that that's going to have on our patients, which are, of course, your constituents. So I'm pleased to be here today to talk about the facts of the new law and how it's going to implement our state-directed payment program, which is called the Hospital Rate Improvement Program, or we call it ATRIP for short. So for those of you who might not be familiar with the program, ATRIP is a Medicaid state-directed payment program. It allows Kentucky Medicaid to access additional federal funds at no cost to the state. Our hospitals pay a provider tax to cover the state portion of the cost of the program. Currently, hospitals are able to receive 95% of the statewide average commercial rate for both inpatient and outpatient Medicaid services. And that's very crucial because base Medicaid payments are well below the actual cost of providing care for Medicaid patients. In fact, Medicaid base payments cover about 82% of the actual cost. Importantly, ATRIP is also a value-based payment program, and hospitals have to meet specific quality metrics to earn a portion of the payments. So perhaps unsurprisingly, with the additional resources that ATRIP provides, hospitals have been able to focus on quality, and quality has been measurably improving in a number of areas. Our hospitals have been investing in more training and undertaking additional measures to improve health outcomes for patients. Unplanned readmissions are a significant cost driver for Medicaid, and because of ATRIP, we've seen major improvements in the readmission rate. We've been able to reduce unplanned Medicaid readmissions from a double-digit percentage to a single-digit percentage in just a few short years. And this has been made possible by the wise use of ATRIP resources. We are also focused on treatment of sepsis and reducing infection rates, and we're seeing success in both of those fronts. KHA had established a sepsis consortium that all of our hospitals participate in, and that consortium has allowed for the sharing of best practices, training, implementation of procedures that identify sepsis early and get patients to quick treatment, and that's saving both lives and money. ATRIP has made it possible to screen 96% of all the patients visiting the emergency room for sepsis, and if they screen positive, getting them to quick treatment. Other infections have been reduced due to ATRIP providing critical resources. And this reduction in infections, it's good for patients, and it's saving the Medicaid program money because it's avoiding the cost of longer hospital stays. Opioid use is also being reduced thanks to Kentucky's statewide opioid stewardship program that KHA established in 2019. Quality measures from that program have been incorporated into ATRIP, and there's been a sustained focus in reducing the number of opioid prescriptions. Virtually no patients leave the hospital with multiple opioid prescriptions, and alternative pain management has become the standard for things like ankle sprains and aftercare for non-complicated vaginal births. ATRIP is also allowing hospitals to focus on new mothers in a way that wasn't possible before we had these resources. This is important because half of all the births in our state are covered by Medicaid. Postpartum depression is a real and present danger to the health and lives of new mothers. ATRIP has allowed Kentucky hospitals to screen new mothers for postpartum depression and substance use disorder within 2 weeks following discharge from the hospital. If patients screen positive, they're referred to resources. ATRIP has also allowed hospitals to screen for suicidal ideation. Over 1 million patients visiting the emergency room have been screened. As you may know, suicide is the second leading cause of death for youth and young adults, exceeded only by traumatic injury. We often hear about the social determinants of health, and what that really means are things like food insecurity and lack of transportation. These determinants of health are important drivers in unplanned readmissions. Hospitals have used ATRIP resources to undertake screening and referring these patients to resources when we find things like food insecurity. Hospitals are also partners in the new Food is Medicine program, along with Commissioner Jonathan Schell at the Department of Agriculture. This program, while not part of ATRIP, works in conjunction with it to help patients receive more fresh local Kentucky produce and proteins, and it's benefiting everyone. KHA is very proud of the role we play in the functioning of ATRIP. We're proud of the quality improvements, and we are very excited, and we have been up until the passage of H.R. 1, about the potential for further transformation of healthcare in Kentucky. We've provided training for more than 1,000 people in the short time of the ATRIP program has been in place. We've engaged top experts to help hospitals have access to the best information and best practices for treating patients. And we also collect data for our partners at Medicaid, and we provide feedback to our hospitals to improve their performance, because of course this is a value-based payment program, and all hospitals need to improve. ATRIP has allowed hospitals to invest in their staff, both with training and salaries. And at a time when there's been a wave of hospital closures and staff salaries have been stagnant in other states, ATRIP has provided the resources to allow staff pay to keep pace with inflation. And as a result, vacancies for all hospital staff, as well as for registered nurses, have been reduced 40% since 2022 with the help of ATRIP. Fewer staff vacancies mean better care for patients, better outcomes, and reduced readmissions. So to sum it up, ATRIP has been absolutely transformational for healthcare in Kentucky. Without ATRIP, Kentucky hospitals would be operating at a negative 7% operating margin. That would mean less access to vital treatments, less access to care in general. Sadly, there are those who don't want to hear these facts. To be perfectly clear, the margin numbers are not developed by Kentucky Hospital Association. Kaufman Hall, a consulting firm routinely relied upon by state agencies in Kentucky, has studied the impact of ATRIP and reported that because of ATRIP, hospitals have, on average, a 2% margin. Without the ATRIP program, that margin will drop to an average negative 7%. While hospitals in many ways are not typical businesses, no business can operate very long at a loss. And that means without ATRIP, hospitals are going to be forced to reduce services, lay off highly trained and talented staff, and in some cases cease operations altogether. There's been a great deal of talk in the media about potential hospital closures because of the phasing down of our ATRIP program. Those numbers come from the Sheps Center at the University of North Carolina. The Sheps Center has studied hospital closures across the country for many years, and it's a well-respected organization. And according to the Sheps Center, Kentucky faces a loss of 35 hospitals because of the phase down of state-directed payments. KHA cannot say certainly exactly how many or exactly which hospitals might close. The number could be greater or less than what the Sheps Center predicts. The bottom line is that the ATRIP program is being phased down by 90% over a period of several years. And that is a fact available for anyone to read in H.R. 1. According to the formula in the new law, when it is fully phased in, Kentucky will lose approximately $2.2 billion for ATRIP. and probably another almost $1.5 billion from our teaching hospitals. And that's a $3.6 billion loss to the state. It can't help but have a negative effect for healthcare in this Commonwealth. And that's not fear-mongering, it's simply a fact. The KHA is simply dealing with the facts based on available studies and the funding formula in the new law. And those facts tell an ugly story about the future of healthcare in our state. We don't have to speculate about these matters because we've seen the loss of services and hospital closures in states that don't have a program like ATRIP. The good news is the impact will not be immediate. The phase down does not begin until 2028. So the logical questions are, how did we get here and what is the path forward? So sometimes a page of history is worth a volume of logic. The KHA worked very closely with Chairman Guthrie in developing the House version of the new law. He carefully balanced the needs of our hospitals and the savings needed to meet the requirements of the federal budget resolution. Chairman Guthrie and the staff of the House Energy and Commerce Committee, they listened to our advice and the information about how our ATRIP program works and what should be the national standard for how these programs work. Chairman Guthrie was able to preserve the program, and we embraced the need for a work requirement and other common sense provisions that he needed. In fact, KHA had supported the work requirement when the Bevin administration first sought to introduce it. The Kentucky delegation in the U.S. House was very helpful in working with Chairman Guthrie and in approaching the Speaker of the U.S. House to pass the Guthrie-designed bill. Chairman Comer, Chairman Rogers, and Congressman Barr all answered our calls for help. The Executive Office of the President of the United States reached out to KHA to ask for our endorsement of the bill, and we were happy to endorse the House-passed version. Unfortunately, the product that came from the U.S. Senate was dramatically different and a great disappointment. As U.S. Senator Bill Cassidy of Louisiana said, Guthrie used a scalpel to make the necessary changes to Medicaid. Unfortunately, the Senate then applied a chainsaw to it. One of the things the U.S. Senate did not seem to consider was how the loss of resources in Medicaid will close services for all patients, not just those covered by the Medicaid program. When the bill returned to the House, despite efforts by Chairman Guthrie and with the support of the rest of the Kentucky delegation, there was just no way to make further changes to the bill with a July 4th deadline on them. So that leaves us to deal with the consequences of a phase down of a program that was approved by the first Trump administration and continued by the Biden administration. In fact, I was in a meeting with the head of CMS at the federal level over Medicaid who praised the Kentucky program for having the gold standard for how the program should work. So despite gains in quality from our state-directed payment programs, and instead of allowing our program to continue, the new law cuts the program over several years and caps Medicaid payments at the Kentucky Medicare rate. The Medicare rates are federally set using an antiquated formula that takes money out of Kentucky and other southern states to pay more to high-cost states like California, New York, Connecticut, and Massachusetts. A discussion of the Medicare payment system flaws is far beyond the time we have today. But what you need to know is that the Medicare rates in Kentucky are so low that Medicare and Medicaid pay essentially the same and pay well below the cost of care to deliver care to patients. So the bottom line is that when the cuts are fully implemented, the ATRIP payments will be virtually wiped out. The new law's phase down of the provider tax will also limit the ability of Kentucky hospitals to access all of the dwindling available funds for the ATRIP program. Rural hospitals are most at risk because they treat a higher proportion of government patients. Demand for care is rising. The cost of delivering care is rising. all at a time that Medicaid reimbursement is being cut. While the Senate bill contains a rural transformation fund, we've heard today it's unclear how much money Kentucky will receive. While half of the fund is equally divided, the rest of the money is going to be determined by HHS. One thing is known. Whatever Kentucky receives, it will only be a fraction of what ATRIP provided. Hospitals are already starting to review which services will have to be curtailed or ended once the phase down starts. Sadly, that will also entail determining which and how many staff positions will need to be eliminated. Our association will, of course, continue to work with our federal partners to attempt to correct the flawed phase-down provisions in the new law. We will also be seeking your support for changes both at the federal and state level. The hospitals understand that the state cannot replace billions of dollars in federal funding, and we appreciate the support of the General Assembly in being such a great partner with us over the years in support of ATRIP. We're likely to come to the General Assembly with a proposal regarding the state hospital provider tax that hospitals currently pay, but which does not support hospital services. Also, support for the 340B drug pricing program is going to be even more important now as we lose ATRIP funding. We also understand that some don't wish to believe the facts about the future of the ATRIP program and the consequences it will have for both access to care and the economy of our state. And that's their right. But we must make every effort to find ways to serve our patients in the face of potentially devastating loss of resources. Our patients don't have the luxury of pretending there are no cuts to Medicaid. So with that, thank you again for having me here today. I wish I had better news to give to you. I would just say we are very eager to work with you and to be a resource to you as we work together to address the Medicaid challenges that we're going to be facing. I'm happy to take any questions.
Sure. Thank you very much, Nancy. And I don't know, you may or may not know the answer to this question, but is there a likelihood that the feds will revisit some of the portions of this big, beautiful bill? Or, I mean, are conversations still happening around that possibility?
We hear all sorts of things.
Okay.
We've heard actually they may come back and make more cuts to Medicaid. I've heard everything.
Okay.
I think that our delegation, they listen to us.
Yeah.
And so we will be working closely with them to see if there is a path forward to hopefully make some corrections here. As I said, the Medicare payment system, we are so disadvantaged, as are other states. Mm-hmm. And so that's something that we'll be trying to work with some of our other counterparts to look at making those changes as well. But it's going to be an uphill battle. I don't think this is going to be easy, that we're going to just go up and say delay it or change it. So we're preparing for the worst.
I just didn't know if those conversations were ongoing. That's helpful. And you think, well, it's a delayed implementation date, so we'll have time to figure all this out. It'll be here, in a blink of an eye.
Yes.
So this is really, really critical that we start to talk about this and get all the facts out on the table, because it'll affect so many lives and so many people's well-being. So thank you for, it's a sobering presentation, but it's definitely a necessary one that this committee kind of start to noodle on and think about.
Thank you.
How we do things moving forward. Does anybody have any questions? Okay, I have Representative Marzium.
Thank you, Madam Chair, and thank you, Nancy, for a very depressing report. We've been doing this a long time. My concern is in your first part about the 35 hospitals, the rural hospitals that are going to close. Do you have any idea of locations? I know you don't, and do you know how many employees 35 hospitals would affect that would be out of jobs?
Nobody wants to be labeled that they're going to close. The Sheff Center list was looking at hospitals that are highly Medicaid dependent, so that's going to put them more at risk. it's going to look different in every community, and no hospital's going to want to close. They're going to try everything to not close. And so as I've talked to my members, they're looking at all the services they offer, because most services that hospitals offer, the payment is not adequate to cover the costs. There's a lot of subsidization of services. And we all know what those services are: OB, behavioral health, emergency care. And so they're going to look at that, and they're going to have to make some hard decisions about what they are going to have to discontinue and what they can continue. And so I don't think closure is going to be happening right away. And some are on, even with ATRIP, we had hospitals, that are still just sort of breaking even.
Right.
So it's going to look different across the state. I will say 60% of hospitals' costs are in their staff, their wages. So, we ran some estimates across the state and estimated it could be up to 20,000 jobs lost when you're taking billions out of the hospitals.
Thank you for that. And can I ask one more question?
Sure.
Thank you. So you're looking across, or they're looking at their services, OB. So you get a rural hospital that closes their OB department. So then you're looking at a travel to Lexington, or walk me through what.
Well, I'm not saying OB is going to close, but I look at what's happening in other states, and we can look and see the types of services that close. And OB is oftentimes the first thing that closes. It's, you do see emergency rooms closing. You see behavioral health that has closed. Those are the types of things that they are money-losing services, and sometimes those are the first things to go. And yes, we know there's maternity deserts here in the state, but the hospitals, I'm not saying they're going to close OB. They may want to try to maintain that service and cut other things.
Okay, Chairman Petrie?
Thank you. And thank you for the presentation. And I'm going to hearken back to Secretary Hicks and Secretary Stack, and comments made about the rural transformation, healthcare transformation, and the fund that's going to support that. First, listen to the issues makes you think, well, we've got less money, we've got closures, and we just have to draw down the system. I don't know that that's the only option we have, and I think that transformation fund and the plan that has to be gotten on yesterday is going to be the most important piece out of this. And to pick up just on a word that's in that, transformation, not subsidization, not find a new revenue to continue doing what we were doing, but it will be an opportunity and a challenge to transform the way we think about rural health care and the ripple effects of that. Very much with what Secretary Stack was saying, and I would say challenge-wise, each of us and everyone else, how good of a job can we do to reimagine, and transform how that type of health care is provided more effectively and more efficiently? And we have about a 5-year window opportunity to accomplish it. I have no doubt that Kentucky is best and well situated to do that. I see that as an opportunity challenge. And I hope we all take it up and work together to do that, so that over these next 5 years, we have a better system than we had last month. Thank you.
Thank you. Inspiring words. And, we do this all collectively. We'll all hold hands together and figure this out, because it requires us to figure it out. So thank you very much. Do I see any further questions from board members? Chairman Fleming?
Thank you. I appreciate your presentation. We have talked before about the situation y'all are in. I'm just curious, Secretary Stack and I were talking about that letter sent out. I think the KHA has a copy on that. Do you have any plans to look at some type of cooperative approach with other associations that's listed on that letter to come up with some thoughts and solutions and opportunities?
Well, we're going to start with our own association. We have 128 hospitals. We do have a board committee that's formed. They're meeting next week, so we'll take our advice from them. But we hope to move very quickly, but we do need to gather input from across the state from all of our members.
Senator Berg?
Thank you. And you may not know the answer to this question, but when you're thinking about transforming rural health care, you need the hospitals. You also need medical staff. What is this reimbursement? What is this bill going to do for a physician and other healthcare reimbursement? Is it going to impact it the same way it is for the hospitals? Like, are we going to have to struggle even more to get providers and pay and keep them?
Yes. Yes, because the hospitals were using the HRIP money
to pay.
This is why we have 40% fewer vacancies in our hospitals to
Right.
increase pay to, recruit staff. And so, yes, I think it will impact that.
Oh, okay. Seeing no further questions, thank you very much for your presentation. And as you all know, her contact information is on there if you need to reach out for anything further from Nancy. Okay, now we get to the speed round of the Moab. We have 4 people who have scheduled to speak at our open mic. And I just want to remind everybody, it is a 3-minute open mic. I have my John Schickel timer up here, if anybody remembers John and his egg timer. And so I think the first person who signed up is Michelle Sanborn. And I don't know what buzzer I have on here, so it could jolt us into, the next committee room.
Hello, I'm Michelle Sanborn, President of the Children's Alliance. Thank you for allowing me to speak today.
Thank you.
The Children's Alliance would like to make 2 recommendations on a different topic than today, but timely topic. Number 1, we recommend to the Moab to require new Medicaid fee schedules be posted no later than March 1st of each year for an April 1st implementation date. Currently, CMS is required to publish the new rates in the Federal Register by November of the preceding year. New behavioral health rates in Kentucky were just posted in July of 2025 for an April 1st effective date. Delaying in posting the new rates is very inefficient for providers and payers. And if we're having to reprocess all those claims, we would like to see if we can get those ahead of time so that we can implement those timely. Recommendation number 2, increase Kentucky Medicaid behavioral health rates to 100% of Medicare rates so Kentuckians can have access to care and we can effectively compete for behavioral health professionals in Kentucky. Medicare rates are typically about 90% of the cost of care based on national studies, these rates, and they would still be lower than the average of surrounding states for licensed behavioral health professionals. We printed some PowerPoint presentations with 2 charts comparing some commonly used behavioral health services with surrounding states and comparing some commonly used services with some states used in a DMS multi-state rate study that they began about a year ago. Comparing those states, only 2 states have lower behavioral health rates than Kentucky, and neither of those states border Kentucky. It's difficult for Kentucky providers to compete with 7 bordering states, paying significantly higher rates for behavioral health professionals. In addition, in 2005, Kentucky reimbursed associate-level therapists $78 and 40 cents an hour. Today, that reimbursement rate is only $78.67 an hour. We're paying 27 cents an hour more for therapy from a master's level therapist than we paid 20 years ago. Yes, 20 years ago. Consumer Price Index indicates that $78.40 has the same buying power as $132. If Kentucky's going to meet the behavioral health needs of our children and families, we need to increase behavioral health rates.
All right. Thank you very much. You had 30 seconds left. I appreciate your presentation, Michelle. Okay. All right. Next up is Matt Holds.
There we go. Hello, esteemed members of the board, and my apologies for my terrible handwriting. It's Dr. Matt Holder, and that's the physician handwriting. I'm sorry for that. My name is Dr. Matthew Holder. I am a physician who has been working with the intellectually and developmentally disabled population for 23 years in the Commonwealth of Kentucky. I'm affiliated with the Lee Specialty Clinic in Louisville. You may or may not know at the national level, and I'm sorry I don't have the Kentucky numbers, they're a little harder to find, but at the national level, we spend about 16% of the Medicaid budget on people with intellectual and developmental disabilities. So to put that into perspective, that's more money being spent on this population than is being spent on people who are having heart attacks, or people who are having stroke, or people who have cancer, or people who have diabetes. And you probably couldn't imagine physicians graduating from medical school not knowing anything about heart attack or stroke or diabetes or cancer, but I can guarantee you that every physician graduating, and that has graduated for generations, does not know anything about taking care of people with intellectual and developmental disabilities. So what happens when you take a very complex population and you turn their care over to a very untrained, very unprepared workforce? You get very expensive and very bad outcomes. That's the bad news. That's the current state of affairs as to where we are right now. The good news in all of this, when you are paying a lot for very bad outcomes, is that there is opportunity to improve. So our clinic, we opened a different clinic in another state under a managed care rubric. And what we sought to determine, and what the payers determined for us, was the impact of the overall cost of care of providing a very laser-focused matter of care to this population. And the results essentially were that we decreased the overall cost of care of this population by 44%. In a very short period of time. So it wasn't over 20 years. This was a very short period of time. And so by producing that kind of cost savings, just to put that into perspective, that would mean roughly a $5 million investment in this type of care would produce roughly $15 million worth of savings. I point that out because specifically $5 million, we are actually looking to expand our services into Northern Kentucky, and that's about what that would cost. So there's some savings there, but that's not my message here. My message here is to say that there is no world in which we could operate our clinic at fee-for-service levels. You could double fee-for-service and we still couldn't operate. You could triple it and we still couldn't operate. Yet, even at that, we would still be saving money with our program. So as you continue your deliberations, what I would like you, just my message is please focus on alternate payments, value-based methodologies, and things that focus on outcomes. And if there's anything that we can do for you in the realm of outpatient care for people with intellectual disabilities, we'd be glad to help. Thank you very much.
Thank you, Matt. You were right at you had 1 second left.
Perfect.
Okay, next up we have Sarah Carter.
Good afternoon. My name is Sarah Carter, and I am a single mother working as a social worker and counselor at Mercy Health Paducah Cancer Center. I became a single mother when my son was 1.5 years old. At the time, we lived in Tennessee, and this was before Medicaid expansion with ACA. I was a working full-time college student when I became pregnant and in an abusive relationship. Once I gave birth to my son, I no longer was covered under my mother's insurance and did not qualify for Medicaid at that time. It was only covering children and those with disabilities in Tennessee. I'll never forget I got strep and couldn't get in to see a doctor anywhere without insurance. Thankfully, Walgreens had started opening many clinics in their pharmacies at that time, and the provider took pity on me and saw me free of charge. I was running a temperature of 104 and was in pretty bad shape. Luckily, my son was covered by Medicaid, as he was sick a lot when he was an infant and a toddler. During that time, we received SNAP benefits and WIC, and without those programs and later Medicaid, I'm not sure we would have made it. I was able to graduate from college with a bachelor's degree in animal science, and 1 year later, my son and I, with the help of my mother, moved to Colorado to continue my education. Colorado thankfully provided Medicaid for both of us, as we also continued to utilize SNAP benefits. And a few years later, I graduated again with an associate's degree in veterinary technology and became working as a certified veterinary technician. Sadly, working full-time in that career field and working a second part-time job, I didn't make enough to afford insurance coverage through my employer. So we continued to benefit from Medicaid and SNAP. My son's father never paid the court-ordered child support and eventually lost visitation. A few years into working as a vet tech, I realized I'd never be able to support us on my own. So I began taking the prerequisites for nursing school. During this time, me, my son, and my mother moved to Kentucky to help provide care to my grandmother, who was in the advanced stages of Alzheimer's and required around-the-clock care. Thanks to Kentucky participating in the Medicaid expansion, my son and I continued to receive much-needed insurance and care. One thing I've not mentioned is I have multiple chronic illnesses, including Crohn's disease and also chronic migraines that developed when I had preeclampsia at 19 weeks gestation with my son. I was told by my OB at 20 weeks that my son, who is now 17, would likely not survive. We made it to 38 weeks, but I continue to suffer from frequent migraines that require ongoing care from a neurologist. Medicaid is incredibly important as it has played a huge role in our lives in getting the care we needed. After moving to Kentucky and taking a sociology class at West Kentucky Community and Technical College and working as a CNA in a local hospital, I realized, sorry.
You can finish up real quick. You have one more sentence.
All right. Well, I went on to work in oncology, and having Medicaid for our patients is incredibly important. Oftentimes they are no longer able to work, and that impacts their ability to receive care. And without Medicaid, many would not survive. So thank you.
Thank you. Thank you for sharing your story. And our last presenter today is Meg Bowden.
Didn't get the memo on dressing up.
You look great.
Thanks. Are you gonna? You've already started it.
You want me to stop it?
Yeah, I want the finger up when you've started it.
Okay. Tell me when you're ready.
Fair rules. Go ahead.
All right. You're on.
My daughter June is 10. She was diagnosed at 3 months old with epilepsy, cerebral palsy, and it was already going deaf. At the time the neurologist diagnosed her, he told me and her father she would live a year, maybe 20 tops. We've gotten 10. Today, I am actually an employee of the Kentucky Department of Public Health. I work for the Early Hearing Detection and Intervention Department. I also work for a lawyer out of Elizabethtown as a medical representative so I can summarize cases for Social Security disability for Kentucky residents. The other things you don't know about me while I sit here in front of you is that I have left Kentucky a lot for the care for my daughter. I've paid a lot, thousands and thousands of dollars outside of this state to seek the proper medical care. I've gone to Michigan, Los Angeles, and Cincinnati a lot. And anyone that you know that has a child with special needs will tell you Cincinnati is where it's at. So now, here's the thing. I have a very unique perspective on Kentucky and the systems that it operates in order to serve your residents, our residents in this state. There are a lot of intra-agency communications that are left not happening. I'm not saying that on behalf of the Early Hearing Detection and Intervention. I'm saying it actually when I receive my Medicaid papers, because even though I work for the Kentucky Department of Public Health, I am on the expansion plan for Medicaid in this state. I've been so since 2015 when I left my job in order to care for my disabled child. Now, I used to work for the department, for the library department in Louisville, Kentucky. I had a great job. I was my family's breadwinner. I have a bachelor's degree. I'm actually now in the process of getting my master's degree. You cannot hold me down. I am too busy doing all sorts of things, and you also can't hold me back from the care that my daughter deserves. I will leave the state of Kentucky in order to get that care. Now, when I came back from Los Angeles the first time, I convinced the Kids Center, the Cerebral Palsy Kids Center on Eastern Parkway in Louisville, Kentucky, to change their model of care. It took me 5 years, and I kept telling them, listen, I am paying thousands outside of this state. I'm funding it privately. I'm asking our family members, but I'm asking everyone and being able to pay people outside of this state. Now, some of you in the back of your minds might say, I don't care if a family who's disabled leaves this state. That's fine. But I still am a taxpayer. I'm still contributing. My husband's business this year will gross $100,000. That is your tax money. And there are 600,000 of us in this state that have children who are disabled and who need services. Medicaid isn't something that you should be ashamed of, and Medicaid's something that I'm not ashamed of. But we can be a lot more versatile in the way that we're handling our state agencies. We can communicate a lot more clearly, and I'm sorry, I'm not trying to throw anyone at all under the Kentucky Department of Public Health under the bus. What I'm talking about is that when I have Medicaid, you all send me paperwork every year that shows me what I paid in taxes and then what I'm allotted for support from the expansion plan, right? You already have that information on my taxes and for what I'm allowed to get in those on those other subsidies, right? You already have that information. You know when I get a new job, I fill out a W-4, I fill out an I-9. There should be no reason why Medicaid expansion shouldn't be communicating with the Kentucky Tax Revenue District and saying, hey, who just got a new job? Do we actually have to do this thing every 6 months, or can we just communicate with our agencies already and be a lot more versatile and technologically advanced? Okay, I know I'm over.
Thank you. Appreciate that. Those are very helpful comments. All right, well, that wraps up the portion from the public. And I think this will work really well. I'm kind of excited about hearing from people sign up, and I think it'll give us a really interesting perspective as we go through this. Before we adjourn, I do want to give the board a heads up that we are probably going to start moving at a little faster clip. Don't be surprised if we may have 2 meetings in September to go through some of this material. And so stay tuned. And my co-chair, do you have any parting thoughts? Okay. Anybody else have any parting thoughts? Yes, Commissioner.
I would just like to say that it is a wonderful day that we are having this meeting. Today is the 60th anniversary of the signing of the Medicaid law. So I think...
Well, how about that?
It's wonderful.
Yeah.
And I think that Ms. Carter and Ms. Bowden, thank you so much for your comments and demonstrating the importance of the Medicaid program to an ever-increasing population. Thank you so much.
It couldn't end on a better note, so we are adjourned. Thank you, board members.